I'm Dr. Dungy. Why are you listening to me? I'm not sure why, other than I do a lot of work with Harrison, and they thought that with our relationship that I would be a guinea pig to come down and do one of their presentations so they can learn and then get the real professionals in there, but that's fine. I graduated in 1986 from dental school, University of Minnesota. I went to a GPR in Pennsylvania, the VA, and that was awesome because all we did was dentures and partials. Then I came back and I worked in the community clinics, the model cities, the South Side community clinics, all those things that are funded by the government. And the advantage we had there is that you dealt with an environment of individuals that were depressed financially. So we did a lot of dentures and partials. So I got a chance to do some of that. I also taught at the University of Minnesota in the pre-clinics and the clinics as soon as I got back from my GPR. So I got a chance to be around some people and fine-tune some of that knowledge that I had. And then eventually I went on and I worked for the Metros, the Park Dentals, and then I started my own practice in 2005. So that's me. So what I'm gonna do is just kind of take you through my thought process. I'm not a prosthodontist. Doesn't mean this is the perfect way, but I'm just gonna share my thought process as I'm going through something. So we have a patient, and on the schedule says patient wants dentures. So before I even sit down, the questions I have to myself is, am I going to be successful? How am I going to be successful at this? And so I have a checklist that I pull up, and it says, the first thing I want to know is, what are they coming with? Do they have a denture? Are they needing immediates? I have one patient who just didn't like her teeth and wanted all her natural teeth extracted. Not my favorite conversation. I want to know how old the denture is. I want to know how many dentures they've had, right? I want to know, is the bite okay? I want to know about vertical dimension. And I want to know, their reason, why are you here? Okay. So I want to make some general observations. And on my checklist, the first thing I want to know, like we talked about, is why are they here? Well, I want a new pair of dentures because these are worn. I like them, they're worn, so I want a new pair. Okay? Or I lost my denture and I need another denture. What I want to do is I want to see what I'm starting with. And so to some of the questions that we talked about, I want to know what I'm going to be starting with. I want to know where those frenums are. I want to know where the hamular notch is. I want to know about the incisive papilla. The reason that's important to me is if you ever seen a patient who has a denture for a long period of time and they have natural teeth on the bottom in the anterior, they pound away at that section. And what happens is the bone resorbs, but the gum stays there, so it gets a little floppy. But underneath there is a nerve, so you got pressure pushing on there, they're going to feel like their mouth is burning in that area. So that's one thing I want to know about when I look at the top. The number one thing that I want to know is that patient a gagger? When I sit them down, I'll be talking to them and I'll look in their mouth and I'll take my finger and I'll go all behind in the back to see if they're going to gag. Because if they're a gagger, I'm going to have a problem, right? I'm going to have a problem with impressionings. I'm going to have a problem with the denture staying in place. Don't be fooled. I've had 2 patients who have dentures came in and said, well, I'd like a new denture. Not thinking, I said, well, they already have a denture. They're probably not a gagger. Start to go make the impression. It's like, oh, well, I started to develop this gag reflex over time. So it's like, okay, let's add that to the list of checking. So you really want to know. That's my number one thing. Because if you're a gagger, then I'm going to have trouble with the denture. And if you're not a gagger, we're going to have a pretty good thing. On the bottom, the way I learned it, the things that that we wanted to really be focused on where that denture was going to sit was on this thing called the buccal shelf, the buccal bone, and the retromolar pad. If people have mistakes, they're usually short of the retromolar pad. And what that does is when that denture's made and it's short and they bite, it digs in. If it sits on that pad, you have a chance of that kind of being absorbing, shock absorber. When it misses that, it kind of digs in. And so that's a place that you'll start to adjust the occlusions just so they don't bite so hard. And over time, that ridge will wear down. So you want to know where the retromolar pad is. You want to know where the buccal shelf is. The inside, that's going to be a place that you're going to get your undercuts. So kind of getting a feel for how big that undercut is something that's going to help you not only there, but in the impression. Okay? And of course, the challenging thing is we never have enough ridge here.
How often do you send anyone to oral surgeons to get what you want?
A lot of the patients that I have are people who don't want to spend a lot of money. So when you start to talk about the things that you need, you go through that list and then you start to find, well, I don't want to do that, I want to do that, I just want you to make this. And so then the question becomes can I make it? For example, a patient who has a large amount of bilateral lingual tori, you're going to have a hard time getting a denture to fit there. And then I just tell them I won't be able to make a denture for you unless we get some of these things cut away. So it's a tool. Where I work is in Farmington. If I was in Edina, I probably would be doing more of that. But in Farmington, it's really about, I don't want to spend a lot of money. So that's the environment I'm in. But I would definitely encourage those things, especially frenectomies. You just think that, well, is that really necessary on a patient that has a denture? But if that's going to be in the way of the denture seating, it is an opportunity to have that denture fit better by examining your frenums and seeing if they need to be, plastied a bit. Does that help? Yeah, and anytime I'm speaking, if you have a question, just let me know or just yell it out, okay? The next thing that I want to talk to the patient about is what do you expect to have? Because they always come with the expectation of aesthetics, right? Well, I want my teeth to look like when I was 30. Or, what these examples are, sometimes people come up with things that aren't quite on your path, or they're an Eden apple, but they think they're a full apple, or that's what they want to look like. That's why that's there. So you have to manage that. As soon as you sit down, you can say, I can do this, but I can't do that. One of the biggest things that I've run into is over time that a patient has dentures is they develop an underbite, right? Because as this wears that way and the ridge wears down, you get the underbite. And they always want that corrected, okay? So the one question is, well, can I correct it? Part of the reason that you have that problem is either a closed vertical dimension, meaning that they're closed too far, or skeletally they're just that way, or placement of the teeth over the ridges, okay? So we manage that, and then you ask yourself, no, that's fine.
Oh, all right.
Yep.
All right.
Am I going to make this denture, right? I just had a patient in today. She has 5 through 11, and they're all crowns. 5 is periodontally involved, and we're going to lose it. We've been telling her she should get it extracted. So her question is, well, how can I replace that? And so I said, well, are we going to replace all the teeth, or are we just talking about replacing that one? We know that an implant's too much for her. She's like 86 years old, doesn't want to do an implant, doesn't really want to do, crowns or, maybe 2 crowns and an extension. She would like something removable. And then the question becomes, her main goal is just replacing number 5. And I can make a great denture that fits around number 5, a flexible denture, except I don't think she'll be able to get it on at all, right? She's got to be able to grab it. So are we going to extend further out or figure out some way for that? And oh yeah, I'd like this done by Christmas, and oh yeah, I don't want to take my tooth out before Thanksgiving, right? And you start to see the requests that come, and then they kind of put it on you like, well, we can't get that done by that time, we can't get this done. But understanding what the lab can do for you is how much time they need for each step and how many steps you're going to have. You got to say that up front. This is what we can do. And long story short, once she figured out how much it just costs to replace that one tooth, she finally said, you know what, I think what I'll do is I'll just take the tooth out and I'll just see if I can live with it, right? So after all that discussion, because her expectation was she just was thinking about that one tooth. She wasn't thinking about occlusion. She wasn't thinking about having a denture. She was just thinking about the one tooth. So sometimes we got to get on the same page with the patient. What is it that you're trying to accomplish, right? And then I ask myself, can I do that? If she has an existing denture, and how's the vertical dimension? How's the bite? Maybe just relining that tooth, that denture is enough. Or if the denture fits but the teeth are worn, maybe I think about just replacing the teeth, right? Most patients will say, well, I don't want to be without my denture. And so that becomes a limiting factor. And then you say, well, if we're going to do that, if you want to keep this, then this is what we're going to have to do. But what happens often is patients will kind of keep pushing us to try to get this at a certain time without really understanding all the things that we have to do. So what I found is if you tell them why, and tell them this is what our expectations are together, then they ultimately fall in line, okay? So you got to map it out step by step. Step 1, step 2, step 3, step 4. Let them know, okay, it's going to be 5 weeks from today you're going to get your denture, if that's the steps that we take. So now they have a goal and they understand it. So the way I was taught and the way I still do it is if I have a complete denture over a complete denture, I'm going to take, my first appointment is going to be a primary impression so that I can make a custom tray. To your question about overextensions is, do you have a tray that's going to help you not make an overextension? So I'll always make a custom tray. This is what Tom was talking about. If you see these little white spots in there, right? The rationale was that when you make this tray and you take the spacer out and you go in to seat that tray with your impression material, the first places that should hit, in theory, should be that spot, and that spot. And so it should read out as a burn spot in your impression. If that's the case, then you know where to go when the case is done, where you should have high spots. That's the theory behind it. You can do that. You don't have to do that. But what happens here is when you're placing your custom tray for an impression, it's like, where do I place it to start my impression process, right? So to jump back, we took a primary impression. You mark out where you think the denture should be, and you want your tray short of that. The other thing that you have to know is, what material am I using? Why? Because your material that you use, okay, has a certain amount of flexibility with it. What do I mean by that? I mean, if you make a custom tray and you're 5 millimeters short of your extension, when you go to border mold with your material, will your material hold itself up for 5 millimeters, right? That's the reason why they all say you should have your tray cut back 1 to 2 millimeters, because they know the impression material you're using can hold itself up for 1 to 2 millimeters, right? And that's really about the amount that you want to be border molding with anyway. So you make a custom tray based on where you think the endpoint should be, and then you cut the tray back, or you have the lab cut the tray back to your specifications. When I have a custom tray, then I have my second appointment, and I do my final impression. When you guys learned it, did any of you use a hot water bath and compound wax, right? That's how I learned it. And that's really a great way to do it. I don't do it that way now, but that's a great way to do it. And the reason why is because you get to play around with each spot until you know where you're at. The problem is you do that in dental school, you got, what, 2 hours, right? You do that in your office, you got maybe 30 minutes that you wanted to do this with. But what it helped me do, and what this illustration is just getting the peripheries. So what I do now with my custom tray is I'll take my custom tray and I'll take my impression material and I'll put it right here. And then I go in and I border mold it. Okay? And so the one thing that you have to understand about what you have is what is the setting time on that impression material. So all I do is I'll go in, if you have a faster set, minute set or 30-second set, you just put it in and you border mold it. The reason why I go from here to here, because I can manage it in the mouth. I can't manage putting the whole thing in at one time with the patient. So I'll put this in and I'll let it set. Then once that's set, I'll put this in and do the same thing. And then when that's set, I'll put this in and do the same thing. Now, that's how I get my border molding. Because now, once I have my border molding, then all I do is I put my wash in, okay? I do the same thing here. I'll go 1, 2, 3, 4. Because I want to isolate each spot and what I'm trying to accomplish, right? So it's the best of both worlds for me, because it's like doing that the way I learned it, but I can do it faster because I have material that I just use for 1 minute or 2 minutes or whatever we do, okay? Then you put your wash in. The last thing I wanted to point out here is this is what they call the post dam. A lot of people think it's just a half of a Batman signal or something like that, right? What this is designed for is in the back is where the tissue is going to be able to be pushed. If you examine, patients have different places. Right here is actually not that flexible, but it's usually right around here. You just go back there with your ball burnisher and just press in. You'll see that there's certain areas that press in. Those are the areas that you want because it doesn't bother the patient that much, and it's going to push back and create the seal. A lot of times you'll see it like right here. Well, if you examine most patients, they're not that flexible right there. It's usually more lateral, okay? When we knew we were getting ready for this, then I have a patient in the chair, right? And she comes in, we go through that whole thing, and I'm making some impressions. And the reason this is up here is this is just for a custom tray. And this impression I ended up taking 3 times just for the custom tray because I knew something wasn't right here, right? Her tongue was what was causing these spots on my tray. So what I did is I went back and I got a smaller tray. Usually I try to get the smallest tray that I think will fit. She had a smaller mouth. I thought that tray was fine. But when I got a smaller tray, I actually got a better impression. Okay? The other thing, and one of the questions about trays and stock trays, is that tray, you'll see a little mark right there. What that is red rope wax. So when I put the tray in, it was great, it fit, but it wasn't far enough back. So I take some rope wax and I just put it on the back there. So I get something that will basically hold that impression material. So, and if I'm short any other place, I'll do that. You'll see that sometimes when you're doing a immediate, where you're okay with some of the teeth, but some of the places you're short, just take some rope wax to extend your tray. So that's all I wanted to show you here, is that sometimes having a tray that you think is okay is probably your problem because it's a little too big or it's not functioning the way it's supposed to. Once you take your final impression, then we got our bite blocks. So some key things that I'm going to share my first denture case with you guys when I got to my GPR. We had to make a denture, full denture for a patient, and I did everything I thought was great until I got to the end, and we put him in. Dentures fit great, but his top teeth were here. I could barely see him under his lip, and I saw all of his lower teeth because I had missed some steps. I had got a great bite, but did not understand at that point. Again, I forgot the principles of what the lip support and all those phonetic things mean, right? The reason this is here is help your lab out by marking the midline on your case. Just take some floss and go from here to here, and then just mark it so that you can tell, right? There's some anatomical things. If you don't tell them, they'll look for this anatomical marking, and that's where they'll make the midline. And then you might notice that in some cases that's off. Then you got to reset them. Okay? Vertical dimension. You know, they always tell you to pull out this ruler and mark the nose here and mark something here, right? All you're really trying to understand is where the denture is going to fit, and you need 2 to 4 millimeters when that patient's at rest, right? Vertical dimension of rest, vertical dimension of occlusion. So what I do is I take a Q-tip and I just put it under their nose. And then I'll mark it down here because I know their nose isn't going to move. You know those long ones that you put your topical on? Just put it there. And then I have them go through the exercises. Are there certain things that you guys do to try to understand where the vertical dimension of rest should be? You know, the way I learned it was this thing called the M. You just have them say M, 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 and then freeze. You have them, and then you kind of measure that. Then you can have them wet their lips and then slowly close until their lips touch. Tell them to freeze. Okay? And then you take a look at that. And then if they have dentures, have them bite down. See how much change there is. That's establishing your vertical dimension. And it just has to be where they're at rest. More often than not, people are overclosed, which brings me to another question that I want to point out is, should you put them back to the right vertical dimension or keep them where they're at? When I was coming through school, they said, oh, you should try to correct the vertical dimension. But I've never had a patient accept that. Especially the longer they've had a denture, I'll kind of keep them at their vertical dimension, or I'll split the difference. If they've got a very overclosed vertical dimension, I'll only go halfway because they can't accept being at the new spot. One of the reasons why is because they can generate more more biting forces, and then their denture hurts. It's just like your bicep. You know, there's a certain sweet spot that you can pull anything towards you. You can't pull it way back here, and if you're here, you can't generate a lot of force. Is where the muscles have their maximum interaction, is where they generate force. Same thing with these muscles. If they're over open, you can't bite down. If they're over closed, you can't chew either. Okay? So developing vertical dimension is just really easy, just understanding where that freeway space is and trying to just get them to relax and just having them touch their lips and freeze is the first place to get you started. And then what if you don't have dentures? All you have is a edentulous patient. Well, you try to find where that free space is and then just shorten it 2 to 4 millimeters. That's where you would set it. Okay? Sometimes, I like to, in full dentures it makes sense, but sometimes you have partials, sometimes you have some immediates where you have enough teeth for the bite. But what I like about a try-in is it lets you see if all those things you were working on are going to be accomplished. Can you back that slide up once? Okay. The one thing I didn't really talk about that we really do need to talk about is lip support. Okay? One of the things that you want to do is tell the lab where you kind of want to have those denture, that patient's lip at, right? That's why they give you this thing that's kind of rounded. Because they're hoping that you kind of cut it back to give them an idea where that lip should be. Okay? So a lot of the times you're looking at the patient from the side to see where that is. And more often than not, you're going to be a little bit thick. So you're going to have to take that down with whatever device you use to try and get it thin from the side so you can say, okay, that's a pretty good lip support. Also, what you'll have is that occlusion rim will be a little bit thick under there. So you just have to ignore that that's going to be something that's taken down in the final product. So you want to get an idea of where that is. Phonetically, with my friend from the VA, having those exercises where you want to see what that smile line is going to be like, right? When they smile, you should start to see the teeth slide back. Canines, usually what I'll do is I'll say, when you just basically open first, most patients, you can start to see their canine. And then when they smile, you'll start to see back to their first molars. Okay? So I'll kind of play around with the corners of the mouth. Another way that you can help the lab is look for the canine eminence, right? And that should be where your canine is, and you start to measure 6 across, right? It says, well, the dimension of the 6 across is however you measure it, so many millimeters. And they can start to say, okay, well, we'll set teeth that will get you in that category. Saying phonetic words like, the things that I'll use, I'll say very fine, frank, all the F words. Not all the F words, sorry, most of the F words. To see where if that bite block is going to start to hit their lower lip a little bit. Frank, very fine. Then I'll throw in Virgil just to throw them off. Virgil, every good boy does fine. Because I want them talking. And then I'm going to look for the F sounds to see if it hits that lower lip. The TH sounds, right, are where the tongue kind of hits the lower incisors. That one, is not as critical as getting the top one because that's going to be our money line, right? They're going to want to know if that smile looks good. What I did with my friend from the VA is I didn't go through Frank and Virgil, and so his teeth were way up here instead of down here. So then if we go back to the next slide, everyone has a difference of opinion about what they like. Most of my patients they don't like a lot of fancy stuff. I don't over festoon. A lot of them always say, "What? It feels so bumpy. Why are you doing that?" So okay, because they've had smooth dentures, right? But it's nice to have a little fancy down there. But you want to start to see, this is obviously a finished product, but in your try-in, you kind of want to look from the side. What does that lip support look like? When she just starts to open, can I start to see the canines? And if she has a big smile, can I see back there? And does that smile line, does that lower lip kind of follow the tips of the upper teeth? You can kind of see that in your try-in. And then when you get to your insert, you already know you're going to be there. At that point, it's just making sure the denture fits, taking out the undercuts, checking the occlusion. Because once you get to if you've done all your steps right and you get to the try-in, you should be feeling really good about what your product is going to be like. Okay? So those are kind of the steps that I go through. when I'm thinking about a denture. Are there some questions about that? I know it gets kind of nerve-wracking, but I really want to make sure we address your time here.
After the quote statement, just that
Yeah.
final impression, what do you use? Do you use like a mouth softening wax for that functional quote statement?
You know, what I'll do there is I'll make note to myself on how far that depresses, right?
Can you ditch that yourself?
Yeah,
I'll
usually because I've talked to Tom and those guys enough, they kind of know what we want. But sometimes I'll tell them, if it was a new lab, I'd say I want this depression to go down about 1 millimeter. And its deepest point should be in the center. It shouldn't just be dished out, but it's going to follow what happens in the patient's mouth. When we were in dental school, we had this mouth softening wax that we put back there. You know, it's just kind of an extra step for me. It's like, you know, I got to save sometimes some places, right? Because I don't want to keep taking that thing in and out, right? Especially with today's impression materials. It's, you know, they're there. So what I'll do is I'll kind of make a measurement, and I'll try to tell the lab, hey, put a depression in this, you know, just prior to processing. Put that depression in there. You may have to teach them what you want by maybe even sending an example, you know, like maybe from the model for the custom tray. You can kind of dish out and say, I want it to look something like that. That was a good question. See, that was a good question, and you have another good question. Yes?
What types of impression material are you using?
You know, and Tom and I talked about it, because mine is not the most efficient way, because what I do is I have the polyvinyl siloxane 3M stuff for my crown and bridge, right? Because I don't do dentures like every day. I don't have a second one, which if I did, I would get one that set up faster. So every time that I do that border mold, it's a 2-minute process for me. But I'd rather do that than have a second material just sitting around. I said, well, if I have that and I know how it works, I use that. And so, yeah, 30 seconds would be great. 2 minutes. But then I'm chatting with the patient and doing those kind of things. So I use the same thing I use for my crown and bridge, only because it's just cost savings for me. That's a good question. Now I have a question for you guys. If the paste that we use, the pressure indicator paste that we use is that, why do we call it PIP paste instead of PI paste? PIP, pressure indicator paste. That's always bothered me. And you know why? Because when I was growing up, we would do a thing on our little bikes called a wheelie. And if you did a wheelie, you'd pop a wheelie. That's what you do. The next generation of people said, let's do a pop a wheelie. See, they did the same thing. They took the verb and they moved it out. No, you pop a wheelie. You don't do a pop a wheelie. But that's what we do now. We have a PIP. It should be PI paste, but now it's PIP paste. So something to ponder, something to think about. That is my presentation. Yes?
I got a question for you.
Excellent.
Do you do any like flexi partials?
I do.
What are your thoughts on them?
I like them. I think, and what I've seen happen is I think there was 2 different types. There was one type that you couldn't do a reline with, and now they have one that you can, and some of those are a little bit softer. So when I've seen it work well, it works well. And some of it is knowing how to work with the material. Usually either can be too tight or too loose. Can you figure out how to make that better and adjust it? Usually it might be too tight because I have older patients and they're like, this is great, it's a great fit, but I can't get it in and out. Because one of the things that you have to do before you leave the office, you have to be able to take it in and out twice, right? And so it's like, then they're like, can't get it out. Fingernails are breaking and stuff. You're like, oh. So I have to figure out a way to loosen it up for them. So part of that is now understanding that's on your checklist. Can they take this out? Can they put it in, right? And that's the exercise I went with this older lady. I said, I can make a great one, but I don't think she'll be able to get it in and out.
Just to clarify, we cannot reline flexibles.
No.
I can add teeth to flexibles, but we can't reline.
Yeah, I mean, if I said reline, I'm sorry.
Yeah.
It was either
Just wanted to
add teeth or some you couldn't do anything, and now you can. That was the big question: can you add teeth to them?
Is that
Yeah.
like a valve class?
We use
What are you
Duraflex,
talking?
yeah.
Yeah, same
Valplast,
same
you can't add
principle.
you can't do anything, you can't add teeth to Valplast or FRS, but Duraflex we can. They actually have a material that can remelt and be added onto, but the other ones,
Right.
once they're melted and cooled, they're done, that's it.
Okay.
Let me jump in real quick. The Valplast is actually a nylon material,
Oh,
and everybody else's flexible material is an acetyl resin. And nylon's very hard to adjust. If you've worked with Valplast, it's hard to adjust, polish, all that kind of stuff. Where the acetyl resins, they're more, when you grind it with the burr and polish it with pumice, it acts more like an acrylic does then. So it's a much easier, it's more user-friendly material, the acetyl resins are.
how's the longevity of that? I just had a patient with a Valplast,
Yeah.
and she had it about 3 or 4 years,
Mhm.
and that was great.
Mm-hmm.
But now it's just not staying in, and,
Right.
the material's not, you just can't change it, try to heat it up, get the clasps to be tighter. And
As far as
just-
longevity, I don't know, Tom and Jim could probably answer more to that, as far as what they've seen.
Maybe we don't know, but.
Yeah, it hasn't, Valplast has been around for like 40 years and they haven't changed the formula on it, just because it works. But the acetyl resins, they've been around for probably a good 10 years now or so,
Alright.
I haven't really experienced any quick, rapid degradation of it or anything like that, or?
Of course, it depends a lot on their habits, but the one thing I have noticed over the years with Valplast versus Duraflex, after 3, 4, 5 years, you can almost see a porousness in the Valplast material.
Right.
And with the Duraflex, when we see them 3, 4, 5 years, they still are able to have a nice shine, nice polish on them, and they look much more the way they did at the beginning.
When I've added teeth to Duraflex that have been a few years old, they may have a buildup of calculus and plaque on them, but that's very easy to polish right back off, and I can make it look like it was brand new again after I'm done adding the tooth or whatever it is. If they've had wear or resorption and the clasps are loose, if it's a Duraflex, I can simply cut that clasp off, re-wax a new one, matrix, or add a new clasp back on there, and we're good to go again. But we can't do a full reline with it. We could jump it, cut the teeth out, clasp it, and re-inject a whole new base to it, but.
I wanted to get back to your question. Was yours on the functional impression? Was it more from a clinical or after you guys took it and sent it to the lab? For the yeah.
I know this sounds kind of crazy, but we do a wax thread triangle teeth, and then take back the vestibule about 2 or 3 millimeters, just look at the mouth and just keep adjusting that back. Then we put in linol. You gotta kind of play with it. Put it in and get that functional impression right then. Have the patient move it around, they wear it for about 5 or 10 minutes. Send that to the lab. And boy, do those dentures fit. I mean, they just fit like never minimal adjustment. But that's when we had an in-house lab where we could just wrap it up in water. 5 minutes later it was poured up. And
What was the name of that?
Pardon?
The material, what was that material?
Linol?
Yeah, I think that's kind of like a tissue conditioning material. Yeah.
We just call that functional impression. When when they've got those teeth and waxed in, which are, we tell them exaggerate everything.
Yeah.
And then have them drink some, put some water in, rinse some water out, spit out the water. That's fitting dentures.
When I've had in my earlier years when it didn't fit, I would do that to just put that instead of an impression material. I put that in to be more of a functional one and then send that back to the lab. So I have done that. I haven't done it routinely, but it makes a lot of sense because it's going to conform if you know how to work with that material.
Yeah, it just takes a little play with it.
Yeah.
But, I've got to give it some thought how to get it to you in time enough. That stuff can't sit, wait an hour or two. That's got to be poured up. And that was nice what happened in in-house lab, it's poured up within 5 minutes. We had a great top.
Well, Amazon, they'll come and they'll just pick that thing up and take it right back.
There is some shade tabs back on the thing for the Duraflex material, so please help yourself on that. Those are for you, John. Okay.
And one other thing that I wanted to say, you're probably doing this, but if you don't, when you're going to do that immediate denture, tell them, it's going to take about 8 weeks before all that healing, and you're going to reline it again, and you're also going to charge them for that, right? If you forget to have that conversation, then you have a patient that says, well, my denture doesn't fit. Yes, we talked about that because you had all this healing, but, you want to have those kind of conversations with the patient in advance. So, just a little FYI.
I want to add something that I picked up when you were talking earlier. You said checklist.
Yes.
I was at my program last weekend. There was a prosthodontist there. She was talking. She was a huge believer of checklists. Everything has a checklist because, like you said, on that first case, you forgot to do this, that, and the other thing.
Right.
And if you have a simple checklist to make sure that, especially if it's something you don't do like every day.
Right. And
I need to check this, that, the other thing, because you send it to the lab and you're missing that. Now we're calling for it.
well, and then the thing is that you think, I've done this a few times. I just, you just do it mentally, and I'll be surprised, like, oh, you didn't do that, and it's like, well, how did you miss that? So just going through your checklist is just very valuable. It's been that valuable for me. You had a question.
Yeah, it was you had mentioned at the beginning that you'll sometimes transition from an economy denture into a premium denture. When you're doing that, do you find that you still do a reline in the immediate denture at a few months out, and then a year later do you need a premium denture, or what's your?
I think a lot of it depends on the patient, because what I'll try to do is I'll try to get 2 to 3 months. You figure, okay, I got 2 to 3 months. I should be in pretty good shape to now kind of address this. There are some who like to go longer, and a lot of it depends on how many teeth had to be taken out and how well does that kind of fit in the first place. Because you can just add tissue conditioner for a while just to give yourself some more time. It basically fits. It's just monkeying around and telling the patient how not to knock it out and those kind of things. But I'll shoot for, usually we're taking out a lot of teeth, so I got to do something and it's 2 months. Or I think basically just taking them through, I'm going to do this, I'm going to do this at 2 months, I'm going to do this at 4 months, and we're going to reline it again in a year. And if they've heard it and they understand it, and they're on board, they're okay with it. It's when they haven't heard it, and now you say, well, you got to do this, and they're like, okay, so the denture didn't fit, so what did you do wrong, right? So having that kind of placed out before them, and having them understand that there's, some price to be paid with that, has gone a long way for me. Either they say yes or no, but if they say yes, then you can do it the way you want to do it. Okay. Yeah, excellent.
What type of tissue conditioning material or soft liners do you, because I think they all stink. Kind of hard to work with, and they're always feely.
They are, I had one and it just kind of sat there because I don't use it that often, right? And so I usually, if I need one, I'll kind of call my rep and say, what's the best one you got for me right now? So there's not one that I could say that is my default one at this point in time. And I try to stay away from them if I can. Just not because they're not good, it's just that I'm lazy, you know, I don't want to do all that stuff. I just want to,
Well, it seems like usually by the time you go to use it, it's expired.
right.
It was- yeah.
Yeah, I mean, either it's something you got to try to use all the time and you get better at it, right? So. Well, I hope you guys were able to pick up one or two things that made it worthwhile to come today. And I know as we're finishing up, I'd be happy to answer any questions one-on-one as we're leaving. Not a problem for me. I just want to make sure you guys have found it worthwhile to come. And I want to thank these guys for letting me participate. Okay?
Thanks for coming.
All right. Now I'll give you the floor. You get the floor.